Bob has been involved with clinical laboratory medicine since the 1980s and is well versed in the immunology of tick-borne diseases. He has been a director or higher level at a number of nationally recognized esoteric clinical laboratories. Please give a warm welcome to Mr. Bob Giguere.
Thank you for inviting me back again, Dr. Grotto, the Binghamton University, and of course Southern Tier. I do appreciate it, and over the next hour I'm going to try to take you from the great science we heard this morning from a number of other people into how it's transposed or put into clinical medicine as we see it today. And then of course my lead-in will be to get the excellent clinical physicians you have this afternoon to go and take you into how it's treated effectively. Okay. So you all know I'm with Hygienics Laboratories, so that's my exposure. You've all seen these. You haven't seen the one on the right. That's from Paul Mead. Paul's the head of the CDC's bacteriology department at their Rocky Mountain Laboratory. And because you see him on TV once in a while talking about MRSA and other things, he showed me this slide to a bunch of us at Mass General about 2 years ago, and this is where it's going. It's only going to get worse. Is it going to get worse because of one tick? No, it's because the CDC now notes that there are at least 6 ticks they've seen transmit Borrelia. And the one down on the bottom, the Orthodontus hermsii tick, for your own information, transmits hermsii in less than an hour, according to the studies done at the CDC. So this is, as you've heard earlier, the nitrous dirty hypodermic needle. The CDC counts at least 14 diseases we know of that this thing can carry and transmit to its to the host, and so welcome to America. Tick metamorphosis, you've heard about this. The eggs, of course, that 1,500 to 2,000 eggs come out in larva early on, and they go looking for their first blood meal. As you all know, the first blood meal, as you've heard so eloquently this morning, is usually a cute little mouse. They'll have 15 or 20 ticks on them at any one time, and what happens when it gets into the mouse? Let's see if this goes ahead. Went too far. I wanted to show you. I think some of you may have seen this. Let's see if it actually works this time. Yeah, that looks like it's working. So yeah, those white things are actually Borrelia burgdorferi in black and white moving through the blood system of a mouse. You'll notice that they're using this spirochetal shape to keep ahead of the immune response. And one of the other things that's going on that you don't see is the changing of surface proteins. All those things we talked about, heard this earlier this morning about all surface proteins, A, B, C, all the way up. So, like I love this slide. We got to arm the mice. If we could do that and have a vaccine for mice, that would be wonderful. But I'm not going to run around the world with a needle trying to vaccine every field mouse. It's kind of a lost cause. So, as we all heard earlier, there are other vectors that carry this mouse, from the squirrels on up to the chipmunks and on. And of course, you all know, as you heard earlier from a couple of our illustrious physicians, that dogs can actually get a palsy, as I think this poor dog had. And of course, that cat ain't happy at all. So, yeah, I always put this one up because it wakes up residents when I give talks at rounds, and it scares people. Yes, anything that moves, slithers, walks, screams can get ticks on it, and voila. So, why do we call this Lyme disease and the deer tick? Because there you can see about 400 ticks on each of the ears of that pure little deer that was taken down on Shelter Island a number of years back. So how bad have we done this? Have we stopped the deer population from growing? Because you heard earlier there's a 2-year life cycle. If we could eliminate the deer like they did on an island out in up in Maine about 10 years ago, they were actually able to eliminate the deer population, and it worked. But we in the United States, we like deer. As you all know, Walt Disney made it socially unacceptable, and we now have about 35 million of these things running around. So the deer population in New York, not to be left out, has grown considerably, and it continues to grow in the last 4 years, according to your Department of Wildlife and Game, I think it's called. This is the deer population, Chase, and how it's growing, and it's getting worse and worse and worse. And here is, if you can read this, the statewide total of cases of Lyme that have come with this, and you can see the rate per 100,000. Please take a look at your counties, because anything above 25 cases per 100,000 is considered an epidemic by the United States government and the CDC. So we got these unwanted guests. They come into your yard, and some of you even let them in your pools. Please don't bring them upstairs and don't feed them any spaghetti. They love it, but don't give it to them. Get them out of your yard. If you can, run them over with your car or join the NRA and become a gun, get a gun. So, why do we have this plague? Back in '94, yeah, I'm that old. I was invited, because at the time I was with the group at the University of Connecticut, to the CDC Astrophelt meeting in Dearborn. At that meeting, about 500 of us arrogant scientists who thought we knew something about Lyme were invited there by the CDC and Astrophelt. That's the Association of State Territorial Public Health Lab Directors. Wow. And if any of you want to know any of this other stuff that I'm going to go through about this, and you're an overachiever, so the Library of Congress, if you don't believe me, you can buy the 400 pages and just knock yourself out going to sleep reading it. I'm going to give you a synopsis of pieces of it as we go along, and this is one of them. At the meeting, they told us we were doing a great job with hepatitis and HIV. So guys, do a two-tier approach for Lyme. This was 1994, so they said, okay, do the ELISA test and even do the Western blot, follow it up. And we raised our hands because I was with the guys at UConn. We couldn't sit with the guys from Yale, but again, that's a different story. And there were some other people, and we all stood up and said the same thing. These tests don't work really well like they do for hepatitis and HIV. These ELISAs aren't that good. So what did they say? Okay, we'll call it surveillance criteria, not to be used for clinical purposes. Voila. No one pays attention. But this is the most recent CDC Lyme case report. What does it say? It should be emphasized that an epidemiological case is intended for surveillance purposes only. This is the form that your physician or your lab is supposed to report when they come up with a positive lab test. So Paul Mead, I call this his hubba hubba slide. It is the dance of the CDC here from Paul Mead on, let's go back. And he, again, presented this slide to us, what was considered, I guess, a lot of conservative people. I know Dr. Ken was there, Ken Ligner, and a few others were there at Mass General. And it just shows that we're only looking at the tip of the iceberg using this surveillance criteria. He put up this slide at the top, and I always put it up there. And I put it up because I was sitting with Alan McDonald, who's a pretty well-known pathologist in Lyme, and that Western blot put up by the CDC, Paul Mead, was from IGeneX. So even though the CDC doesn't like us, supposedly, he certainly liked putting up one of our Western blots to show how accurate it could be. And of course, about 3 years ago, Jennifer Halsey told people, we may not be looking at the right antigens when we test by Western blot. So Lyme disease is a clinical diagnosis until you make it. An old friend of mine, Ed Masters, who passed away about 3 years ago now, great guy. It was originally known as Master's disease back in the 90s when I worked far more closely, of course. Ed passed away, he was a great guy. We actually named it Master's disease because we had to go and defend him in front of the medical review board there in lovely St. Louis. So we named it Master's disease immediately, and or he wanted it done, so we did. And as we called it, and then now we call it Lone Starry Eye. So here in New York State, this is where we have our, we think Lyme disease testing is bad across the country. Come to New York State where it becomes a real challenge, okay? There are things we do at IGeneX that we cannot sell here. There are statements we make about some of our tests that I cannot make in this state. And so I can tell you that the tests we test for are 3 strains, because those are the ones that Borrelia strains that have been tested by your group in the Department of Health in Albany. The Afzelli and Greeny strains, which really came from Europe. And of course, Willie's strain, the sensitive strep 2, and you can't test for any of the others, or at least tell you we do. So I'm a molecular guy, it's what my training is in. This bug has challenged me since 1991, and it's big. It's the largest spirochete we've ever seen, has 123 genes on it. So when your doctor tries to tell you, oh, it's no worse than syphilis, syphilis has 7 genes. Okay? That's like comparing Derek Jeter to a kid in T-ball. This bug will outsmart everything you give it. You throw it against it, it finds ways around it. It has for years, and I'm sorry to say, will continue to. So, Immunology 101, the guy goes to med school, lady goes to med school. First day, they pull out their pens and they learn about antigen versus IgM, startup and an IgG. Early on, the problem is your ticks never went to med school, so they don't pay attention. So Lyme disease is a clinical diagnosis. The early symptoms, of course, are the rash in many cases. A slight afternoon temperature, according to Joe Burriscano, goes away low in the morning, a little high in the afternoon. You can do that instead of testing. As it disseminates, your joint, it moves to the joints, which it loves to do. It doesn't stay in one joint, so it's really not arthritis. The cardiac involvement we are well aware of, and neurological for children especially because of the affinity of the bug to the facial muscles in children. It causes a palsy. So, yeah, Immunology 101 and Lyme 101 says this is the way you diagnose Lyme. I know we all know this doesn't happen in most cases. You know, this doesn't happen in most cases. Or this doesn't happen in most cases. And this doesn't happen, and these don't happen. So this is mostly work from Joe Burriscano, who passed it on to me years and years before most of you were born. And look for the ear in some cases. Sometimes one or both of the ears will be hot and red, and also around the nipple for the first few weeks post-infection. We don't know why. So the common symptoms, that's why this thing is the great imitator, are all of these wonderful things that happen. And trying to make a clinical diagnosis early on of this disease can be a challenge. And if it's scaly or it hurts, it usually is bite or ringworm. So why do we test then? Well, everyone with MS would rather have Lyme disease. They don't. But let's not give everybody chronic fatigue or fibromyalgia because, you know, there are no tests for those, so let's do that, and that's a lot easier than giving somebody Lyme a diagnosis. And for God's sakes, let's not give them osteoarthritis because a steroid is only going to suppress your immune system more, and honestly, your bug doesn't need any help if it's already in you. So we got a problem, and I tell doctors in your waiting room, and it ain't the 3,500-pound gorilla, it's the little tick sitting next to it. Okay? So here is the problem you see. A clinical presentation looks like Lyme, the test from one of the major labs, or even from time to time, comes back negative, and I can't have Lyme disease, so we got to go chase something else. I always tell people to now consider the MSIS questionnaire from Richard Horowitz. Take that in with you to your doctor. If you think you have Lyme and you've got maybe a challenging physician who doesn't want to believe in Lyme disease, take his MSIS questionnaire already filled out. It's about 5 pages long, and you can download it for free from his website. So your physicians have to choose in today's day and age between the IDSA or ILADS. As you can probably guess, the IDSA guys don't necessarily like me much anymore, as I and the ILADS people do believe in chronic Lyme, and that it does exist, and I'm pretty sure it does, because I've got over 700 peer-reviewed articles that show it does. And this is the latest study done in General Medicine, an international journal. And when you do two-tier testing, you get the right answer a little over 50% of the time. If you just use an ELISA kit, you use it, and you can see that. It's despicable. So, all of the testing techniques, because that's kind of like what I'm supposed to be here to talk about, because everybody did a great job earlier of talking about how the bug moves through and it grows in the body. So let's talk about the different indirect tests, as you heard, that we're going to be looking for, which are indirect tests. They're looking for your body's immune response. And then we're going to look at some of the direct tests, PCR and that like. Some of these are not available in your state. So yeah, we do all of those techniques at our Lubber Lab in Palo Alto, which we just moved over across the lake there to Milpitas, because we needed a lot more room because there's a lot more Lyme coming to us from all over the world. So the EIA tests that your doctor always loves to order because they're cheap and quick. And your insurance company, of course, wants it for the same reason. So these ELISA assays, that's a 96 well plate. We put antigen, or the manufacturer does, that's scored to the edges, the size of each of those wells. Throw in your serum, and if you get an antigen-antibody reaction, which is that thing at the top of here, I know there's a light in this thing, yeah. Forming, you can get, they form an immune complex. That immune complex, using a second antibody, as the good doctor before me, Dr. Wagner, explained very eloquently. And you get a second antibody used to look for that immune complex, hit it with a fluorescent tag, and it glows. And that's what an ELISA assay is. But unlike in animals, we've got a lot of proof, even from the CDC, this technique does not work well for Lyme disease. Okay, in a 2-year study funded an old friend of mine, Steve Dumler at Hopkins. You'll notice Arcott's there also. But regardless of my feelings about some of them, Steve Dumler et al., who's now at the FDA, did an excellent science. He's an excellent person for research. He's a molecular kind of guy with me, so maybe that's my problem with him, because he's a good guy. But his study showed that we're going to answer with an ELISA is about 45%, and that's on about 2,000 patients who came into the 5 centers for the Johns Hopkins over the course of a year and a half. So, confirmatory testing. Since 1994, we've had some knowledge of it, not a whole lot. And does it work? Yeah, it's worked reasonably well in some hands and in some Western blots. And we're going to talk about immunoblots in the next step. Why are we going to do that? First of all, let's step back into why every Western blot isn't the same. This Western blot's a piece of Jell-O. We take it, throw it into the mold, throw the antigens that we think are specific to the disease in there, mix them all up so they're nice and homogeneous, put it between 2 pieces of glass, stick it up on its side, put 8 slots down it, and we pipette in your serum in lanes 2 through 7 and 6 other of your friends or other people who sent in samples. And in 1 and 8 we use controls. This is how every Western blot is done, whether you buy the blot from a manufacturer such as Mardex or Bioscience or one of the other Meridian out in the Midwest. They all use the B31 strain, and this is how the tests are all run. When you pipette in the patient's serum at the top, hit it with a positive charge, that drives Borrelia down. If you have any antibodies to it, it drives actually all your antibodies because they're all positively charged. So it drives them away from the heat at the top, and it spreads them out by molecular weight. And when you disconnect the power, you hit it with a photographic plate like we used to use 100 years ago in photography. Voila, you get those bands that you all hear about. And you can tell the biggest, fattest guys, the 94 kDa, those are the big ones, can't move as far through the Jell-O, so they stop. But the little guys who maybe they're more fit or just quicker, they run all the way down the blot. And that's why we were able to spread them out by molecular weight, by size, which is kind of real important for specificity. So, since I became involved with this plague in '91, God, getting old. We found in studies all of these different proteins are based somewhat as being in a significant number of studies throughout these years. So we're finding these in Lyme studies, all or some of them, that we found are now very specific. So, the problem we will see is that if you're not using a lot of different proteins, this bug changes its outer surface presentation. I'm going to mention that again. And it's why a test that is nice and cheap and quick and only looks at 1 outer surface protein or 2 is going to miss a significant number of cases. Those are not being expressed on the bug at the time, and it may be later they expressed, it may be earlier, it depends on your immune response. So if you do a Western blot, analyzer, according to Steve's work, this was first done in 2005 in JTM, but it was published again in 9, but I always put the original studies because it makes me feel at least like I'm not that old. And so, yeah, the tests work 3/4 of the time, so I tell your doctors, look, if you're going to do a 2-tier approach, only do 3 of the 4 patients you were considering doing it on this week, because the 4th one's going to be wrong. So this all started also back in '94 at that meeting in Dearborn because of 2 pharmaceutical companies. You heard some very eloquent work done earlier by the veterinary medicine doctor, Dr. Wagner, before me, about using outer-surface protein A, which is a 31 kDa, and that's what the vaccine was developed against by SmithKline. The thing, some of you may have gotten it, the LymeConference vaccine. The 34 bioMérieux never got to the market with the outer-surface protein B because SmithKline got there first, put it on the market as the LymeConference vaccine, and bioMérieux said, it's not worth fighting them here. We've been beaten by about a year by the time they would have got through the FDA. So they let it go with the SmithKline LymeConference vaccine, which you all know was taken off the market in 2002. Marketing said it was because no one wanted a vaccine. Okay, let's go back to the statement I made about testing. Target antigens used in the lab are not necessarily the in vitro antigens. That's not me. That's Jennifer Halsey, the head of your anthropod disease program over in Albany. So with IGeneX, you get 31 and 34. Stony Brook also does 31 and 34 because they use a different strain. They use a 297 strain, one of the 3 strains the FDA said we could use back in '94. And so we do at IGeneX, we use 2 different strains, but every test you get from a kit It's based on the B31 strain, and the biggest kit in the market is the Mardex kit, which I did the 510K submission on back with Dick Tilton's group on 2,000 samples before it was submitted to the FDA. We engineered out 31 and 34 because the FDA told us to. So we got those out, and so when you do a CDC criteria, you'll notice there's no 31 and 34 for IgG or IgM. Us and Stony Brook are the only two labs left in the United States that really look for both of those. And it's really important. 31 does stick around, and we see it late, and 34 also. So why do doctors use this, and what is this indeterminate band? Because I get calls from all over the world on a daily basis about why do I see IND on an IGeneX result? I'm going to show you why. Here is band 41, which is a flagella. A lot of bacteria have it, virtually all of them. So it should show up in every patient. But if you look at it on this thing, which is supposedly specific for Lyme, and you look at lane 2, it's pretty easy to see that lane 8, which is the control, is the positive control that we get from the CDC. And it's absolutely stronger in lane 2 than our control, so it's a positive test. But what do you do about lane 3? There's something going on at 41, but it's not strong enough to be called positive. Kit manufacturers allow their kits to be used in an instrument that actually measures the intensity. If it's below the intensity, which is the cutoff point of the control, they immediately call that 0. We at IGeneX, and I think and the boys at Stony Brook in Golitis Lab, read the block with a PhD or a good student who knows what he's doing after many years, who will say that we will say it's indeterminate. Stony Brook calls that 0. We do call that indeterminate, which tells a physician the patient's probably trying to develop an immune response, but can't. Why? And it's for the doctor to figure out. It's probably because cytokine reactions against interleukin 12 or 6 are being suppressed, and your pathway for your immune cascade is being challenged, to say the least. Okay. Okay, I'm not going to bore you with that. The problem with most of the testing you get is you're going to miss a lot of it. Is there a solution? Well, we know of at least 8 traditional Western blot IgM strains here and across the world that we are now testing for. 8 for, and those same 8 are for IgG. But there are different minute differences in each of the protein's size. And so, although in a Western blot, you may get cross-reactivity because the size is so big, it's a blot. It may cross with Epstein-Barr or chlamydia and a number of those bands. When you get to an immunoblot, you're using recombinant proteins. These are absolutely specific to the disease, and they're making my life a whole lot easier when I speak to most physicians who are using them. Because an immunoblot isn't going to cross-react. It's going to be Lyme, it isn't going to be Epstein-Barr if you get a positive back from us. Now, there are other labs doing immunoblots, and I cannot vouch for them using recombinant proteins or how pure they are. I can only vouch for the ones we've got and how well they work. And you can see the immunoblot versus our Western blot. Well, you can't see that, but it just shows that the bands are very, very specific. So by reducing this sensor lattice to specific proteins from a significant number of the different strains, if they're different at all, we show them up here as it does in the P23 band and the P31. That's why you get cross-reactivity. There's so many different things going on. But we're going to tell you, we weren't going to tell you, doctor, which strain it is, because that costs way too much money, and especially since the treatment protocol should be the same. So CDC samples, yeah, we validated this with the CDC. How well did it go with the CDC? After they left us, after giving us double-blinded samples, about 150 of them, they went home, wrote a cute little letter to New York State. Within a month, we had our approval in New York State for our immunoblots. This test is by far, it's an Apple 10 versus an Apple 1. This test is by far the most accurate in the country. And how good is it versus our own Western blot, which had been the peer before? Well, if you look at the immunoblot's sensitivity, it's 90% overall for all of the extra stages, be it early through late, and the Western blots. Remember, we're looking for all the different proteins at all the different sizes. So regardless of the stage of the disease, we are usually going to pick it up. Not in the first month. You can't have antibodies in the first month. It's going to take a while. But after that, be it late Lyme, mid Lyme, we usually can pick it up. Sensitivity is very high with this. And if you take a look at our specificity of this test, it's approaching 100%. overall specificity for our IgG is just about 100%. This is a very, very, very accurate, sensitive, and specific test. So it has effect because what we're seeing in Lyme Western blots, early Lyme convalescence versus early Lyme acute, it does pick it up to convalescence. And this is just more sensitivity and specificity stuff, and I'm not going to brag anymore. So many proteins have been observed to differently synthesize during the infection cycle. This is not my words. This is the original work of Stevenson et al. At the University of Kentucky back in 2002. It has been replicated by everybody from Yale through Mass General, through studies across the United States and the world. This bug is smart. When it comes out of hiding, it often changes its surface presentations. It doesn't do it, I think it's because it folds over on itself. Your T cell, and you heard earlier about macrophage response, the macrophages see this as it comes out of the tissue differently. So they give you a new IgM response. So that's why if you do a Western blot late in the disease and you get an IgM, I'm sorry, it is not post-treatment Lyme. It is active infection. Your bug, that bug has come out of tissue for being in the cyst form. It is in the cell, it is out in the body, and your immune system is still strong enough to see it and produce a T cell, strong enough immune response that'll give you an IgM. And I have another test that I can't talk about here. So here is the timing to when to order during the different diseases. And there are a number of those that you can't use here in lovely New York. The IgX spot, the Lyme dot blot, cannot be used here. The IgX spot is a T cell response test. It is the test that you're going to, in the future, we're going to push through, hopefully, get our approval here in New York. No one in the United States has been approved to do a T cell. Some of the work done on one of the triggers that we're using was actually done at Stony Brook by Ray Detweiler et al. And published on 2 years ago. We're hoping that that impetus will help New York State to allow a test that uses that there's DPQ1 along with the VSLE1 from steer and 3 other specific recombinant proteins to trigger early response. I can tell you that in other states and in our studies, 3 days after a tick bite, we are able to get an IgX spot test positive. Once the immune system kicks over, your T cells get downregulated, that test goes negative at about 6 weeks, and up come your antibodies. That's why we see IgM and IgG. Late in the disease, the use of both a T cell response test, which you can't do here in New York, you can do other places, and either our Western blot or our immunoblot covers the whole array, because that'll give you whether your body is producing an antibodies early on or late on, or just T cell response because of the cascade suppression by Borrelia in late disease. So, but we got a new problem. Welcome to America. And the age of diversity is here, and all of these things called tick-borne relapsing fever. And here are all the strains that have been published on that we know of here in the United States, found in humans or other animals. And where we're going with all of this is the next plague. And what we've got here is you've seen the ones across the top. What you didn't see is the one on the bottom. I actually was up at a friend of mine, Tom Schwann, who retired from the CDC at Fort Collins. I went to his lab there, and he showed me that slide with the yellow on it of tick-borne relapsing fever. This was about 6 months ago. I then got to give rounds down the road at the medical center in Boulder, where none of the residents had ever heard of tick-borne relapsing fever, or the doctors and attendants, which scared me to death. Because that is the Termsii, I showed you the orthodontist Termsii tick. It's disease transmitted by the tick in about an hour to mostly people sleeping in campgrounds in the western hemisphere part of this country. All the people who want to go out there and camp out. And then it gets off and it leaves you Hernsii, which is a lot like Lyme and harder to diagnose. Here is the distribution of tick-borne diseases in the Northeast. You can see we've got tick-borne relapsing fever in every other state that but not here, because you guys have figured out a way to keep it out of your deer, I guess, or more importantly, it's because the state has not approved any testing for relapsing fever, and we've had our immunoblots not approved for that. But they are everywhere else in the country, so you can see that Massachusetts and Connecticut, which jumped on it early, Pennsylvania, they're growing. And And one of the relapsing fevers that's growing the most is Miyamotoi. This is the one Peter Krause published on. It was found in 94, 95 by Dr. Miyamotoi when he was working in Russia. It was found in about 30 or 40 patients. And so he named it after himself, just like the Mayoni strain was named after the male, which is kind of interesting. But Peter Krause published on this in the New England Journal of Medicine back now 6 years ago. Some people paid attention to it, but the problem with Miyamotoi, it is transferred from the one mom tick to about 50% of her offspring. So unlike going from one tick to 19 or 20 that are on the ear of the mouse, this sucker goes from 1 to 1,000 in a nanosecond. So we have seen a growth of Miyamotoi or other tick-borne, they're all part of the tick-borne relapsing fever family, in the last few years significantly high. And I even put that thing back. The University of Tennessee didn't know what they were looking at when they were looking at turkeys, but they found it in 58% of the turkeys all the way back in 2009. That's from the University of Tennessee, published in, I think, in the Department of Public Health in Tennessee's journal also. So, does it look like, feel like the same? Yeah, relapsing fever looks like, feels like, tastes like Lyme. I can't test for it here. Brian Fallon down in New York, Department of Health, NYU there, Director of Neurology and Psychiatry. See, I fixed that. Brian's an old friend. And like he said, the problem's going to get missed because even if you test for Lyme with a good test, you're still probably going to miss it because the tests don't cross over. So, yeah, we got a problem, but the test isn't offered here. So I'm not going to talk to you too much about it, but let's look at direct detection now. There are a number of ways we can test for this bug. The problem with direct detection, the bug hides. You go looking for it, it finds a new place to hide. And it's hide and seek with your immune system that really lasts way too long. I'm a molecular guy, so I always talk about PCR. If you got a PCR positive for Lyme disease from Quest LabCorp, I don't care where in a reference lab or any laboratory that's CLIA licensed, you have Lyme disease. It is active infection. This is a big bug. Would get cleared. If it was dead, it would have already been cleared by your immune system and your body. If you still got a PCR positive, it is an absolute active infection. So if your doctor tries to tell you, yeah, your PCR is positive, but you don't have Lyme, find another doctor. And so we do a multiplex, which means we look for a couple different pieces of PCR. We do a genomic and a plasmid PCR. We do all these wonderful things for it. And is it specific? Yeah, it's absolutely specific. We are going to find Lyme-specific positivity rate in about 30% of active Lyme cases, but not more than that. In your Quest to LabCorp, it's only going to pick it up in 15 to 20% of the patients. And the lab I ran outside UConn, and the lab I ran in Gaithersburg outside the NIH, with our friends at both those places, helping me develop these tests, using their primer sets, doing ones that we published on at our laboratory at the NIH. The specificity is absolute, sensitivity is where the problem is, and it's because the bug is high. Okay? So, let's move on to the next future. The future isn't, as you heard earlier, mentioned quickly by the excellent presentation by Brian later about macrophages. Well, early in the disease, when the bug comes in, your dendritic cells, which are right underneath your skin, pick up this foreign object, they ingest it, they send out the data to your lymph nodes to build an immune response, which takes 4, maybe 5 weeks. But they also send out stuff immediately to your T cells and your NKs. Your T cells become mature, they go looking for it right away, right at the site of the bite, and so 3 days out, you should be developing mature T cells that are mature to Lyme disease and actually looking for it. And so that's early Lyme. But late in the disease, what we see is as the immune system's cytokine response is suppressed, and it's well documented, this is very well documented data that some of the outer surface proteins are definitely affected, outer surface protein C and others are all affected, and your immune response is affected because the cytokines and the interleukins, a number of them are being short-circuited. They're not producing the immune response that your body wants to give, and your immune system is getting weaker and weaker and weaker as your T regulatories and your pro-inflammatories are all being shut down. As this happens, your immune system can't fight off if there are any co-infections, so you're going to see Babesia, but it can't even fight off Lyme. But what does happen is your body does have a second mechanism where they immediately starts to say, hey, I'm not starting to see this bug floating around now. Bingo, T cell response again, but now it's at the macrophage level. So it's the macrophages that are floating around in your blood, not the dendrite X cells right into this thing. And voila, you get a T cell response, and the whole cycle starting of an immune response of producing serology. But again, can't do that here in the state. It's kind of illegal right now, so no one's allowed. But the distribution of all of these diseases, because of the suppression of the immune system over time, is getting worse and worse. This is our map of what we have seen in the last year, and the growth of some of these is becoming rather alarming, to say the least. So I'm going to talk only about the 3 biggest clinical presentations. You're going to hear about it from people far more knowledgeable and capable, like Dr. Ligner later. And I'm just going to glance into them, that if you've got a sharp headache behind your eyes, it's probably anaplasma. If you've got a horse, that's probably where you got your anaplasma or ehrlichia. We see that extensively across Pennsylvania. The other things you're going to see is the Babesia one is the more dangerous. You heard talks about that also this morning, and Dr. Wagner did bring it up on finding it more and more prevalent, and it is. The headache for Babesia is usually global. This is a parasite. It affects interleukin-6, so your immune system is definitely going to get hit down. It's going to get beat up just like the Lyme is. When this is the co-infection, you're going to have night sweats most of the time. You're going to have global headaches. You're going to have a dry, aching cough. You're going to have the chills. And your temperature is going to go hopefully up to 105 or 106. I'm sorry to say that. I'm hoping it does, because that way, at least when you go to the ER, a physician may say, oh, this looks like Babesia. And she'll send you over to the infectious disease guy who actually will treat babesiosis, because the pathologist will have done a smear and gotten a positive test. So again, these are the anaplasma ones. I always tell doctors, if you're going to use doxycycline for Lyme, you're going to shotgun and you're going to take this thing out, so it's not a big problem. Ehrlichia testing that's available, you don't have to use Hygienics, please. The IFA tests and kits by Quest that are out there, that Quest, LabCorp, and your hospitals use, are very good. They're robust. They're going to work. You don't need Hygienics for this, but you do have to be aware that if that headache's right behind your eyes and you've got muscle soreness, not joint, it's probably due to this co-infection. So Babesia is the one I tell you I worry more about, because this parasite can kill, and it will. So the air hunger is usually pronounced. You need a nap in the afternoon, even more than I am at my age, and I'm pretty sure I don't have Babesia, but you need a nap for an hour or two, and the vertigo and other things come along. Here is the problem. There is Babesia duncani, it was mentioned this morning, and it is here. The only way you're going to pick it up in your state, because the only kits that are approved are from McCarty. They don't cross. And there's only one kit out there, and it's horrible to start with. So the IFA kit, where you cannot use for duncani, means you're going to miss it. So what you really do is need to have either the direct smear at the hospital or a PCR test, which will pick up all the different strains, because the conserved regions are the same in both strains. And we have a fish test that actually is approved here, developed by Krauss back in 1998 when he first left us at UConn and went down to Yale. And it's looking for RNA. It's a very accurate test. Works okay, but again, Babesia hides like Lyme. So if you get the negative, it doesn't prove anything. You get the positive, this is RNA. So even the most backward pathologist will tell you, oh, it's RNA, that's live. Because I've had pathologists say to me, oh, it's DNA, PCR positive. Well, that's not live bug. Gives me death. So this is a blood smear. This is what the doctor should be looking at instead of going out to work on his golf game when he thinks of Babesia. And this is the right test. The good news is if Babesia is found by your doc, it will then, by a pathologist, your infectious disease doc will treat you. Well, the reason fish testing is approved in this state is this. We haven't missed in New York State proficiency since 2011. So we have fish test approved, fluorescent in situ hybridization. It's based completely on the work of Krauss's group at Yale, and before that when he was with our group at UConn. And how good is it? Confirms, yeah, this thing doesn't miss. So, in conclusion, I got through these pretty good, and everybody seemed to stay awake. or you were able to sleep with your eyes open. Something I never learned in grad school. I really wanted to do that, especially at Mass General and Etherdome such a. So, Babesia has an IFA, most common test that's out there, because docs don't want to read blots or rather look through microscopes much anymore. It detects all stages, but you're not going to pick up McCartney in this state. You're only going to pick up McCartney. Fish testing does pick up both strains, so that's why a lot of doctors do use it here. And PCR does pick up both strains by anybody. So if you get a PCR from the local hospital, which you probably can't, but Stony Brook will do it, a couple hospitals in New York, cities. I don't know about SUNY up the road in Syracuse, but if they would do a PCR, and it is expensive, it would work. So here's another organism that's in your state that we have a new test for that I can't tell you. Okay? I can tell you a little bit about it, but you can't use it. It's called cat scratch fever. And I'm not going to show you that stuff. That'd scare you to death. So let's scare you to death with pictures. I do that to residents. This is Bartonella 101. This is the easy way to diagnose Bartonella. You look at this, oh God, you need some antibiotics. Yeah. Hopefully Levaquin or something strong, or you'll hear other treatment protocols from people who actually know a lot more about how effective they are and have done them in their own hands, in their own labs, in their own offices rather. Now, we call this cat scratch fever because it looks like a cat scratch. And this is from Martin Freed down in New York, New Jersey on Long Island. New Jersey, the medical center down in somewhere down south. He's a nice guy. But he's a pediatric gastroenterologist. His picture, thank him very much for letting me use it. So I also tell doctors, let's not practice 7-minute medicine. Let's spend a little more time with your patient. Look behind their knees. Those are not stretch marks. They're going a different direction. They're raised and a little red. That is Bartonella. So it isn't because you weigh too much. It's because you got a co-infection of Lyme. And I mentioned Rocky-Mounted spotted fever because it's on the rise here. The good news about, for what it's worth, Rocky-Mounted, it is so pronounced in your hands and arms that you immediately run to the emergency room where the ER doctor can say, it's Rocky Mounted, we can fix this, gives you doxycycline for 2 weeks and it works, and you never have to see that problem again. Bartonella testing, PCR, is allowed here. We can do a PCR. We can also test for Henselae and Quintana in your state, as only other labs can, but you can't use our spot, you can't use our Western blot, and our Western blot looks for all the 4 strains in the United States, but you can't get them here, I'm sorry. Not yet. We have submitted this, and hopefully within the next 3 to 6 months, we will have approval for all of the 4 major strains of Bartonella that have been found in patients in the United States over the last few years. So conclusions, yeah, not often. So the last couple slides here, the list keeps growing. This bug keeps finding new things to give us. We seem to find new ways not to kill it, from Rocky-Mounted spotted fever to tularemia. I always mention Horowitz's 5-page questionnaire because when you go back to your primary care, who doesn't believe in chronic Lyme, you need to have this thing filled out in your hand, so when he says, this is not Lyme disease, you hand it to him filled out, because he's not going to ask you all the questions that are on this, and it's free, and it's can'tgetbetter.com. Okay, so if you take away nothing else from me, remember there are a lot of bad things that live in the woods. Most of them you can see. The ones you can't see are going to give you things you don't forget for years. And your doctor often gets put that, I'm sorry about putting 3282. I had to give a talk up in Augusta last week, and Maine passed a law protecting physicians. It is 30, I'm sorry I didn't update that. Oops, my fault. But you have laws that are supposedly protecting your physicians, and hopefully you will stand behind those doctors you'll hear this afternoon who are treating chronic Lyme, because they're the real heroes. Okay, it's not guys like me running a laboratory and giving them tests that we hope will protect them when they get medically reviewed, because it does. The problem I've seen most in the United States over the last 20 years is physicians continue to use laboratory tests that are inferior, that don't conform to their clinical diagnosis. They use non-CLIA licensed labs from outside the United States to try to validate. We are CLIA licensed. We've been around since '91. We do thousands, hundreds of thousands of samples. We can go toe-to-toe with any laboratory, be it Quest or LabCorp, in validation. Your New York State Department of Public Health has validated us, as every state in the country has. We are the lab that can help your physician when, and it's only going to be a matter of time, The IDSA guy from up the road in the ivory tower comes and knocking. Okay? So look at the cost. This is, you heard a little bit about this from one of the earlier speakers, from Dr. Zhang. This is the original work he did, showing back in 2006 that chronic Lyme costs at least $16,000, whereas if you caught it early, the total cost would be less than $1,300. So the most dangerous test results, the false negative. I have to thank my friend up there, George, up at the University of Calgary, because he's got nothing else to do but look at videos and produce them for earlier running around in mice. Thank you very much.